Welcome to Buckeye Scope. This is session 1 on 6/11/2021. I'm Steph Weber, psychologist at Cincinnati Children's Hospital and part of the Buckeye Scope Hub team. We wanted to just go through some quick agenda items before we get into our session today. It looks like most people have already begun to start renaming themselves, which is wonderful. If I don't see anyone, Jesse, correct me, on their phone, so that's great. Go ahead and continue to rename yourself by hovering over your picture, top right corner, 3 dots, and then rename. If you have any questions throughout, the chat box is available, and you can chat Jesse directly, Jesse Thomas, OSU, or you can just put it in the everyone, and we will take care of it. We also have one of our other team members taking attendance, so please make sure you put your name and organization in the chat box. We also wanted to make sure that you're aware that we have live captioning that can be accessed through the caption button at the bottom of your screen. This topic today is going to get into social determinants of health, an overview of the opioid crisis, and addiction and treatment. And we want to make sure that we always talk about the importance of taking care of ourselves through our sessions. The content that we may go through each session may be upsetting at times and may impact you more deeply and may trigger some personal trauma responses. So take breaks when needed, turn off your camera if you have to, but otherwise we'd love to have you keep your camera on. That's a huge part of the ECHO model. We also wanted to make sure that you're aware that we are recording the ECHO session for educational and quality improvement purposes. And so you're consenting to be recorded. If you don't want to be recorded, you can go ahead and disconnect from the session now. Additionally, we wanted to kind of just give you an overview of ECHO. Some of you we've seen on these sessions before, so welcome back. Others of you are new, and welcome to you for the first time. ECHO is different in that it is not a webinar. It is an interactive community, so we will always have a didactic presenter, and then you as stakeholders from our wonderful state of Ohio's different systems and agencies, as all communicating and supporting each other. This is an all teach, all learn model, and so we really expect everyone to be engaged, asking questions after the didactic, and helping out when the case, or what we're calling now is the challenge or opportunity, is really an opportunity for us to all learn together on what resources are available in our state to help these children and families. So if you haven't presented a challenge or opportunity in the past, please consider doing so. You can reach out to Jesse after the session and bring us something that we can help you with. Again, when presenting any information, we always want to keep that de-identified. We've already talked a lot about renaming your profile. If you want to raise your hand, you can do so as well from the participants list, and there should be an option for raise hand on the bottom left corner. Credit for attendance, we're doing it a little differently this time, so we wanted to offer Buckeye Scope as what we call a closed cohort. So we want to try to build that community of practice amongst folks that come the majority of the sessions. So you must attend 8 out of 10 sessions to receive continuing education and professional development credit. And we have that through Step Up to Quality in Okra, DODD, and OSU College of Social Work for this time. All right, we really, again, encourage you to use your webcam and have your microphone available because we will have breakout rooms later open. Introducing our hub team, thank you to Andrea for pinch hitting here on the slides. She is a clinical psychologist and my counterpart at The Ohio State University, and we've been working together on this work since about end of 2017, which is really exciting. My name is Steph Weber again, and I'm at Cincinnati Children's Hospital. We have Elsie Bush representing occupational therapy, also from Cincinnati Children's. Michelle Raleigh-Roberts, licensed clinical psychologist from Creighton University. Ohio is her hometown, so welcome back. John Kinsel is our infant mental health and early childhood specialist. Kristen Kerwin, Stacy Lee, and Sue Meeks, as well as Joe Mayo, are also our nurse navigators from our Athens County area in Ohio University. Andrea, if you want to go to the next slide for me.
I'm trying, sorry.
There we go. We also have Aaliyah Keeley and Troy Hunter, who are developmental specialists from the Ohio State University Nysaunger Center. Amber Clark is a social worker in the TIP program, the Therapeutic Interagency Preschool at Cincinnati Children's Hospital. Leslie Razorbecker is a speech-language pathologist on our team. Kathy Wettig is a neonatologist, recently retired, but we're still going to claim you at Cincinnati Children's, Kathy. Pam Williams-Aria is our developmental behavioral pediatrician from Cincinnati Children's. Michelle Hendricks is also fantastic adoptive mom and advocate. And I apologize, I introduced Jo as a nurse navigator, but she's a peer support recovery specialist. So we're excited to add her to our hub team. An overview of the sessions upcoming will be session 1 today. Our presenter is Dr. Nicole Knighty, who I'll introduce shortly. In 2 weeks, we will have peer support with Dr. Emily Kaufman and Evan Rooney. Session 3 will be with our hub member, Dr. Kathy Wettig, on toxic neurodevelopment, and that will be really our dive into neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. Session 4, we're going to do a focus on fetal alcohol spectrum disorder. We've heard from our communities that they want more on this topic, and so Dr. Pam Williams-Aria will be doing that for us. Session 5, we have the amazing John Kinsel talking about difficult conversations and taking care of ourselves. Session 6 will be new this iteration on intergenerational trauma and infant mental health by Dr. Adrienne Fricker-Eli. We have Dr. Michelle Riley-Roberts coming back for session 7 on traumatic stress in children. Session 8 and 9 we've had before on substance exposure and language development with Dr. Leslie Razorbecker, and then sensory concerns with Kathy Krebs. And then finally, because it was such a great session on models of care during our last Buckeye Scope, we wanted to talk again at the end on session 10 around systems barriers and opportunities for changing overall systems for these kids and families. And that will take us to October 15th, hard to believe. So today's agenda is that we've already gotten through the introductions. We will have a core didactic from Dr. Nicole Knighty, do some clarifying questions. Then we will do a breakout room where you'll introduce yourselves and kind of talk about your big takeaways. We will then have our member from the community talk about the challenge and opportunity that they want to bring to the group. We will have another breakout and then come back together for a whole group discussion. Dr. Nicole Knighty, who is an epidemiologist and assistant professor at Cincinnati Children's Hospital in the Division of Biostatistics and Epidemiology. Her research is focused on the etiologies and effects of maternal mental health conditions, specifically substance use around the timing of pregnancy. So she has a wealth of knowledge to share, and she's going to work on sharing her screen now.
Thank you for that introduction, Dr. Weber. I have no financial disclosures other than I care a lot about moms and babies. And when Steph, Dr. Weber and I work together, she says I'm the peanut butter to her jelly because she's really passionate about kiddos and I'm really passionate about moms. Sorry, my share screen is a little wonky today too. And as Dr. Weber had said, I'm an assistant professor and my work focuses on maternal mental health, substance use, and care. And so we have a lot of learning objectives today. And so it's likely that you'll feel like I'm giving you this really high overview of each one. So I'm happy to take more specific questions at the end of the talk, or you're always welcome to send me an email. But I'm going to start with just a really basic overview of substance use disorder. And then I'll talk a little bit about the history and the trajectory of the opioid crisis in the United States. And I'll tell you a little bit about what's going on here in Ohio. And then I'll introduce the basic tenets of social determinants of health. We'll define stigma and how that relates to substance use disorder around the timing of pregnancy. We'll discuss some of the brain changes related to substance use and that impact on behavior. And then we'll talk about some of those evidence-based practices for the treatment of substance use disorder, specifically opioid use disorder around the timing of pregnancy. And if at any time you can't hear me, just send me a message in the chat. And so really briefly, substance use disorder is a chronic health condition. It's diagnosed by recognizing several symptoms. So here on the screen, you'll see examples of symptoms from the DSM-5. And to be diagnosed, an individual needs to have at least 2 of these symptoms. Historically, our studies on substance use have largely focused on men. And then probably in the last couple of decades, we started to see studies that included women, and then studies focused on women. And then finally, a lot more work focused on substance use around the timing of pregnancy. And what we have found from those studies is that among adults who have been diagnosed with substance use disorder, 1 in 3 are women. And only 1 in 5 adults in treatment for substance use disorder are women. So we found they're less likely than men to receive treatment. And then recent studies have started to show us that women are more likely than their male counterparts to experience some health and social consequences related to their substance use disorder. And this is particularly relevant related to pregnancy and parenting. So the lifetime prevalence of a substance use disorder among women is around 7%. The time period that a woman is at her greatest risk of having a substance use disorder is between the ages of 18 and 29. And this is really important because this age range coincides with the reproductive years. So there's been a lot of studies that have looked at risk factors for the development of a substance use disorder. And then there's also been studies that have looked at kind of the consequences of or the downstream effects of a substance use disorder. Each of those studies have found kind of these same factors. So it's kind of hard to disentangle what comes first. But overall, they find that individuals who live in poverty or with low income, have a history of or current experience with domestic violence, food insecurity and malnutrition, and co-occurring mental illness and inconsistent healthcare. These are all things that are commonly associated with substance use. And so substance use around the timing of pregnancy often mirrors what we're seeing in the rest of the country for not just pregnant individuals, but individuals who aren't pregnant. So I thought we would talk a little bit about the US timeline related to the opioid crisis in the United States, as well as some data from Ohio. And so historically, when opioids were first used, they were used to treat acute pain. Oftentimes they were used for pain in terminally ill patients because it was thought of at that time that they could be addictive. There's high potential for abuse. In the 1990s, pain was introduced as a 5th vital sign. And around the same time, OxyContin was approved by the FDA. And then in the early 2000s, pharmaceutical companies started to really aggressively market OxyContin, and they assured doctors that there was really low risk of abuse. And if you take the time to go back to the literature and look at the studies that they used to assure individuals that there was low risk of an abuse, this came from one study that was more of like a case report, so it wasn't your typical scientific study. So it's always really interesting to look back to kind of see why that kind of made it through. And then in the early 2000s, pain control was included on pain satisfaction measures. So if you are hospitalized or have an interaction with the healthcare system, oftentimes you'll get a survey in the mail. And so this is the type of survey that I'm talking about. And so this put some pressure on clinicians to control pain better. And it's thought that this is part of the reason why there's this increase in use of OxyContin and other opioid painkillers at this time. In 2015, we saw in the United States that the life expectancy dropped for the first time in 100 years. And around the same time, we had a 6-fold increase rate of opioid-related deaths. The last time prior to this that life expectancy had dropped was in 1918 for the 1918 flu, which a lot of us now have learned about due to the COVID epidemic. And then finally, in the fall of 2017, it was considered to be a national public emergency. And so in Ohio, we have seen similar patterns as the rest of the country related to the opioid epidemic. However, we've been considered to be this hotspot. And so we've been disproportionately affected by the opioid epidemic than other states. So I pulled a couple of graphs from the Ohio Department of Health that kind of contextualizes this data. And so in Ohio, prior to 2007, death from a motor vehicle accident was the leading cause of death. So you can see that in the graph where it's the light blue color. But then in 2007, deaths from unintentional drug poisoning, so essentially overdoses, surpassed motor vehicle deaths and became the leading cause of death in the state of Ohio. We can look at the trajectory of the opioid epidemic in terms of how many opioids were prescribed to our population in Ohio. So on this graph, the blue line is the amount of opioid pain relievers distributed by grams. And the green line, it's the amount of unintentional drug poisoning death rates. And as you can see, as we increase the amount of opioids being prescribed to Ohioans, we also saw this similar trend and an increase in drug poisoning death rates in the state. Another way for us to look at and kind of measure as epidemiologists the rate of substance use, particularly related to opioids in the state, is looking at how many newborns are diagnosed and hospitalized with neonatal abstinence syndrome, which you'll learn a lot more about from Dr. Wettig in July. But as you can see, similar to the other graphs, that in the early 2000s, we saw a stark increase in the number of hospitalized newborns with neonatal abstinence syndrome. This next slide doesn't show us a trajectory in terms of time, but I really like it because it shows us how the opioid epidemic has burdened some areas of our state differently than others. And so this is a picture of the state of Ohio, and you can see each county outlined in white. And this is from 2015, and it's showing you the percentage of children removed from the home due to parental opiate abuse. So the counties that are in blue, they have really low rates of removal due to opioids. But if it's in orange or red, they have high rates. And so I think that you guys will get these slides shared, and I recommend going to this link because this is an interactive resource. And so when you hover over each county on the website, it will tell you the exact percentage. This county right here in 2015 reported that 100% of children removed from the home was due to opioid use. And so in public health, when we try to understand complex health conditions or exposures, we rely on a lot of different frameworks to kind of think about what's happening. And so I'm going to introduce you to a couple of frameworks that I think are really important to know about for the opioid use disorder, as well as substance use disorder in general. And so one of my favorite frameworks is the biopsychosocial model of health. And so what this does is it kind of shows you in this Venn diagram that all of these things are really important. So it's important to consider the biological risk factors, the psychological, as well as the sociological. So you can see that an individual's genetics are important, their mental health is important, as well as social support. And so you see that it's this intersection of all of these factors that are important when we're understanding these conditions. And so I'm kind of pulling this apart a little bit more. We've had a lot of studies that have looked at the biological piece of substance use disorders, and what they have found is that the biological underpinnings of a substance use disorder, so kind of like trying to figure out what accounts for how much risk related to the underpinnings, is that genetics accounts for about 40 to 60% of the risk of a substance use disorder. And so in these genetic studies, what they did is they compared individuals who had a substance use disorder to individuals who did not have one. And what they found is that there's certain genetic variants that are more common in individuals who have been diagnosed with SUD than individuals who have not been diagnosed with SUD. And I'd like to point out too that the identified genetic variants vary by substance. And so you might have specific genetics that are important in understanding the risk of alcoholism, but there will be different genetic variants for things like opioid use disorder and other substances. So I like this because I like to tell people that substance use disorder is not this homogeneous condition, that there's a lot of differences to think about in terms of substances and other things. And so another field that's been emerging to kind of help us better understand substance use disorder is neurobiology. And I am not a neurobiologist, so I'll give you that disclosure right away. But neurobiology is simply the study of the organization and the structure of the circuits in the brain. And so when we study substance use, we're really interested in the reward circuit. So what the reward circuit does is it regulates our response to activities that promote survival. So oftentimes this is eating, sleeping, sex. And when you do these activities, you get this feeling of pleasure, and it stores this memory in your brain that you want to do it again. So to keep us alive as a species. And substance use strongly activates that reward system via dopamine. I'm going to try to play this video. I hope it works. Maybe.
Just make sure that it's also sharing your sound.
Let me know if you can hear it. If not, I will do something.
And memorable, so you would want to do it again and again whenever you feel hungry. Drugs of abuse hijack this system, turning the person's natural needs into drug needs. The brain consists of billions of neurons, or nerve cells, which communicate via chemical messages, or neurotransmitters. When a neuron is sufficiently stimulated, an electrical impulse called an action potential is generated and travels down the axon to the nerve terminal. Here, it triggers the release of a neurotransmitter into the synaptic cleft, a space between neurons. The neurotransmitter then binds to a receptor on a neighboring neuron, generating a signal in it, thereby transmitting the information to that neuron. The major reward pathways involve transmission of the neurotransmitter dopamine from the ventral tegmental area, the VTA, of the midbrain to the limbic system and the frontal cortex. Engaging in enjoyable activities generates action potentials in dopamine-producing neurons of the VTA. This causes dopamine release from the neurons into the synaptic space. Dopamine then binds to and stimulates dopamine receptor on the receiving neuron. This stimulation by dopamine is believed to produce the pleasurable feelings or rewarding effects. Dopamine molecules are then removed from the synaptic space and transported back into the transmitting neuron by a special protein called dopamine transporter. Most drugs of abuse increase the level of dopamine in the reward pathway. Some drugs such as alcohol, heroin, and nicotine indirectly excite the dopamine-producing neurons in the VTA so that they generate more action potentials. Cocaine acts at the nerve terminal. It binds to dopamine transporter and blocks the reuptake of dopamine. Methamphetamine, a psychostimulant, acts similarly to cocaine in blocking dopamine removal. In addition, it can enter the neuron into the dopamine-containing vesicles, where it triggers dopamine release even in the absence of action potentials. Different drugs act in different ways, but the common outcome is that dopamine builds up in the synapse to a much greater amount than normal. This causes a continuous stimulation, maybe overstimulation of receiving neurons, and is responsible for prolonged and intense euphoria experienced by drug users. Repeated exposure to dopamine surges caused by drugs eventually desensitizes the reward system. The system is no longer responsive to everyday stimuli. The only thing that is rewarding is the drug. That is how drugs change the person's life priority. After some time, even the drug loses its ability to reward, and higher doses are required to achieve the rewarding effect. This ultimately leads to drug overdose.
So in addition to the biological components of substance use disorder, the area that I spend the most of my time working on is focusing on social determinants of health. And recently, the term social determinants of health is getting a little of an overhaul. So now we're starting to talk about it as social influencers of health. So it seems a little less deterministic. But nonetheless, it's defined as conditions and circumstances in which people live and things that shape their health outcomes. So some people say it's anything that's a non-medical factor that can affect your health. And so when we look at social determinants of health, we use this lens to think about the different levels of causes. And so it's the level of cause relates to how close it is to that individual. So a distal cause is something that's really far away. And so it could be political, cultural. An example of this would be education, housing access, air quality, things like that. Then we look at intermediate social determinants of health, and these are more of relationships and social contexts. And then proximal is what's closest to the individual. So this can be their behaviors, and it can also be potentially their biological risks. So maybe their genetic risk of a substance use disorder. So an example of applying this lens to a health, another condition other than substance use, particularly health disease, is in this table. And so a distal cause of heart disease is potentially having low income, which would limit a person's ability to get healthy food. And then intermediate would be in a low resource neighborhood where they have limited access to green space or places where they can safely exercise. And then proximal, related to that behavior, is eating unhealthy foods and lack of exercise. And the reason why it's really important for us to kind of separate these out by the levels of causes is it then helps us to better understand what types of prevention methods are needed for these individuals. Let me see if I can, oops. So I thought we would do a activity together, and hoping you guys will participate in the chat, or you can unmute yourself. But I was wondering if anybody can think of a distal social determinants of health related to opioid use disorder during pregnancy. And so you're welcome to put it in the chat or just call it out.
The biggest thing that I see working in the hospital with pregnant moms and kids who have parents who are addicted and things like that is just the lack of resources, especially in Washington County. There is this kind of like cultural, like I describe it as like a white picket fence kind of environment. And so it's difficult for people who struggle to actually be able to find the resources or even feel like they can even reach out for that kind of thing.
For sure. I like that metaphor of a white picket fence. I definitely have kind of heard that through other people that I've talked to. Does anybody else have an idea of a distal or now maybe an intermediate social determinant of health?
Thanks to Sarah Carr for putting in historical trauma, as well as Fran, low-income housing and unemployment.
Yes, for sure.
I also
and then
saw
what
transportation.
Oh, go ahead.
Sorry, Nicole. Transportation as well.
Yes. And what about any proximal social determinants of health? So these are more behaviors and biological risks.
Other substance users in the family or friends.
Yep, for sure. And so I'm hoping that we can continue to have an interactive webinar. So this is more, is to kind of talk about this a little bit more deeper. So in this picture, you see the Empower Project Journey Map. And so in a project that I co-lead with Dr. Weber, we had a group that includes clinicians, academics, community partners, and most importantly, we have individuals who have a lived experience of substance use during the time of pregnancy and postpartum. And so what I really like about this map is you can really start to see all of those social, biological determinants or influencers of health. So I just wanted to give everybody a few minutes to look at this map and then to call out what social and biological determinants of health that you see in this map. And you can think about it in terms of risk to use substances, risk or likelihood to be able to receive treatment, as well as other outcomes for these families. I'll start with, while you guys are looking, the biological piece, because I think that one's the one that's kind of hard to find in this map. But if you see in the upper corner where it says both my parents were addicted, this gets at the idea of maybe there's a genetic component to the risk of substance use disorder, but it also has another piece of it too, of thinking about growing up in a home where both of your parents are addicted and thinking about the other social determinants of health that kind of has for those people.
Brittany mentioned that also in the chat, and then Carly mentioned the ducks in a row to keep CPS away.
Hey, Carly, do you want to expand on that at all a little bit? This is one of my favorite pieces of this map, so I'm glad that you called that out. I don't know if I see.
It just feels like a constant struggle. Like they can't, they do one thing correctly and then something else falls. Like they're constantly juggling all of these balls to try to keep CPS away instead of just trying to do right by their kids and right by them. They're constantly focused on the concern that CPS is just going to show up. So I feel like that's just a constant struggle, especially if they've been involved with CPS before.
For sure.
We also have Donna mentioning shame in the chat box, and that's huge, I think, for a lot of these women who experience not only just the historical trauma throughout their lives in multiple ways, but the shame that comes with that.
Yes, and I think the shame and then the connection to stigma, which we'll talk about next, but in all of our interactions that we've had with our moms, shame and stigma comes up over and over again related to the stigma and the shame of substance use, but particularly using substances as a mother.
Diana also added the feeling of never being good enough on many levels. Absolutely.
Yeah, for sure.
I'm sorry. Go ahead, Nicole.
No, go ahead.
I'm struck, so we talk about the ducks in the row, and you've got this layer of the shame, and then you just see, you see the transportation problems, all of the appointments that the moms have to keep. It just, ducks in the row is like, it's a great way to say it, but it's almost like so much more than just that one row, right? It just, you kind of from this map see all of the different things they're dealing with, and then they also have their own, internal struggles.
Yeah, and I think it's more like herding cats. It would be a better analogy for this one.
And we also have in the chat that when people don't experience a lot of positivity in their life and something to look forward to, then that kind of gets into that spiral of what's the reason to stop using. And then Brittany also brings up the really important part about transportation. And when you see that in this map of appointments to keep and having to walk in the snow and rain, and not having a car or a driver's license, but still being required to get to multiple appointments per week, sometimes in the same day. So,
yep.
And
then with this story with the mom walking right here, I remember when she was talking to us and she would say that she would get home and her socks would be wet and it would be in the wintertime. And just the idea of like walking to your prenatal care appointment and just having like wet socks, which is the worst feeling to have. And then with the transportation piece too, of finding and navigating resources. So a lot of our moms would say, we know that there's all of these things out there for us, but it's much harder it's so hard to get them. It's so hard to find them. It's so hard to use them. We had one mom say, I know that I can get all of these things for my baby from this organization, like a crib and a car seat and a changing table, but I have to first get there. And then I have to not only get there, but have a truck to bring it all back. You can't carry it back on a bus. And so there's, like Andrea said, all of these different layers and all of these different pieces that really affect the outcomes for these families.
Walking in that weather is tougher when your boots and your coat have been stolen at the homeless shelter.
Yep, exactly. And so like with them, that was a good point, John. So with the family that talked to us about that, they had said like, during pregnancy, they were trying to collect all of the things they would need for their baby. But if they would leave the homeless shelter, then all those items were had the potential to be stolen, and they were stolen. And so it was just really hard for these moms to get the things that they needed to care for their kiddos. Did anybody have anything else you wanted to call out about this map before I go on to the next slide? Good, okay. And so part of, I think Donna brought up the shame with the last map is stigma. And so stigma, the idea of stigma, the definition of stigma has been around for a really long time. So one of, I guess, like the forefathers of starting to think about stigma was this guy named Goffman. And in 1963, he had said it's an attribute that is deeply discrediting. And more recently, Link and Phelan have identified 4 components of stigma. One is just labeling those human differences and then stereotyping those differences. and then separating those labeled from us. So that person's an addict and I am not. And then status loss and discrimination. Stigma can be really gendered as well. And so substance use among women, specifically substance use among pregnant individuals, goes against all of our gender norms and our mom norms. And so these individuals kind of even feel a greater burden of the stigma. Something, if you're interested to like kind of see how stigma plays out, I hesitate to recommend this, but I do this often, is whenever you see a news story about something that related to a mom and substance use, if you click on the comments, you will see every example that you've ever wanted related to stigma and othering these women and the comments related to them of really basically treating them like they're not human. And so this is something that we really do need to address in our field and change the narrative about this population. Something that Dr. Weber and I have learned, we kind of knew it before the experience of the Empower Project, but going through the Empower Project and learning how amazing these women are and what fantastic moms they are is something that I like to share with anybody who will listen to me as my part of kind of changing this narrative. And so another piece of the Empower Project that Dr. Weber and I did is we had these things called listening sessions where our moms could answer questions they wanted to answer. And then it was just our job to sit and listen. And so they got the questions beforehand and they told us which ones they wanted to answer and which ones they didn't want to answer. And so on that call, we had one question about how do you think healthcare providers perceive you? And over and over, our mom said, a quote here is, many doctors automatically think the worst of you and you can tell it immediately. So we've had other moms say, as soon as somebody knows that you have a history of addiction, that the whole air in the room changes. And then over and over, it's the stigma that they talk about. They see what they see in the chart. And then related to the stigma is they feel like they're not trusted by their healthcare providers. This also came out when we had another question to them about what kinds of emotions they had around going to a healthcare appointment. And something that stuck with me often, and I think about a lot, is this quote right here in the middle. The stigma around the situation will forever be the reason I don't have more children, which I wish I could go back and change more than anything in my life. And then another mom had said, judgment related to getting pregnant, this is a typo, while on methadone. So she had said that, you know, nurses and other healthcare providers had shamed her for allowing herself to get pregnant while she was being treated for her substance use disorder. And so something that can kind of help us related to stigma when we work with individuals with substance use, as well as kind of talking to just the people in our networks, is stigmatizing language. And so I really like this graph because it's simple and it's easy to read. It was developed by a professor at Harvard, but it kind of talks about which words are stigmatizing and what you can use instead. So instead of calling somebody an abuser or an addict, to use more first-person language saying that they have a substance use disorder. The word that I have been trying to get out of my normal vocabulary that I say a lot is relapse. And so instead of saying relapse, a better, more morally neutral term would be resumed or reoccurrence of symptoms. And so studies have found that there's a lot of negative consequences of stigma. And so it can invalidate somebody's personhood. It's easier to put them to a lesser status. There's the shame. Stigma is directly related to low treatment rates for individuals during pregnancy, as well as the general population, retention and care, and then mental health. Specifically related to pregnancy, stigma can cause somebody not to feel safe to disclose that they're using substances during pregnancy. And it would be really helpful for the health of mom and baby if we knew about the substance use during pregnancy, so you can align the necessary care and resources for these moms. It also relates to a lack of empathy from care providers, again, less likely to seek treatment, and then lower rates of breastfeeding. So although it has been recommended that individuals who are receiving MAT can breastfeed, there's a lot of misconceptions related to the safety of breastfeeding. And so a lot of women are told not to breastfeed because they're using methadone or buprenorphine, when we've seen in other studies that breastfeeding can help reduce some of the symptoms of NAS. So really briefly, There is evidence-based treatment for individuals with OUD. So pharmacotherapy is the recommended treatment by the American College of Obstetrics and Gynecology, because they have found that it is safer to use MAT as opposed to going through withdrawal, because studies have found withdrawal can cause the uterus to contract and then cause preterm labor. There is medication-assisted treatment, which is the combination of the pharmacotherapy, counseling, and behavioral therapies. And this includes both methadone and buprenorphine. Both have been approved to treat OUD. And the special thing about buprenorphine is it can be prescribed and dispensed in the physician's office, and so it increases access. And then the last slide is to note that there are disparities in treatment that we need to start addressing. We know that individuals who are younger and who are Black and Hispanic are less likely to receive treatment during pregnancy. And so I'm happy to take any questions, and sorry for going over time.
No, we asked you to do so much in such a short time. We really appreciate it. Again, these slides will be available on our Canvas Learning Management System site that you'll get information to sign up for after the session. So at this point, I think there was one question earlier on in the talk about the genetic predisposition. Is that related to a deletion or duplication? And I think your video kind of answered that it's more related to neurotransmitters, but I wanted to see if you wanted to take that question, Nicole.
Yeah, so I'm not an expert in the genetic piece of it. I know it's more related to genetic variants, but in terms of duplication and insertion or a CNV, I'm not positive.
Great, and feel free if you have other questions. I think I saw someone at one point raise their hand and then it went away and I couldn't see the name, so I apologize for that. Feel free to unmute yourself and ask questions, and I will be monitoring the chat box as well. But there's some great discussion going on around the journey map and some of the barriers and stigmatizing language and just societal stigma in the chat. So make sure you check that out as well.
Steph, it was me that had the question. This is Katie Black. I was wondering, with children's, is there, I know Children's Hospital focuses on the baby, of course, but what can a mother do in the Cincinnati area for that time period of postpartum when she is struggling with this topic?
That's a great question, and I think it's very varied across the whole state. So our work on Buckeye Scope is really focused across the state, but Nicole, do you want to talk a little bit more about what we're finding as maybe some recommended practices, and then others that maybe are involved with the different organizations throughout Ohio? Feel free to chime in as well. That's a great question.
Yeah, thank you for asking, Katie. And the postpartum period is an area that I've started to spend a lot more of my research in, because we know that these moms have their greatest risk of overdose in their lifetime, 7 to 9 months postpartum. Unfortunately, most of our research has focused on pregnancy and the baby, and we don't know a lot about what's happening to moms that first year after delivery. And we know that a lot of them lose their Medicaid insurance within a few months after delivering a baby. I spoke with a group yesterday about a potential need that they would have during that first year, and it's related to childcare. So they had said that, sometimes these babies are born with complex healthcare needs, and they have a really hard time finding somebody who will babysit this child or finding a daycare center where they feel safe to leave their child. And so these moms aren't getting a break, and they don't have a great support network to leave their child with. So that's, I think, an intervention that I just started thinking about, and I called Steph right away after that call. So they have a lot of needs and a lot of work in that area. I don't know if I answered your question.
You did, and I resonate with a lot of things that you guys said. I'm a postpartum 3 weeks with my newborn, so I get it in a way.
Thanks for being here.
Yeah, thank you.
Other questions about the topic? I think one of the things that I always was surprised when I first started learning this was that the bit that we kind of went through quickly at the end around there is medication treatment, and we expect moms to be able to access that even through their pregnancy oftentimes. And one of the biggest deterrents is being able to get access to that. But we know that babies are more at risk if the mom detoxes even from their medication. And so keeping them at a stable level throughout their pregnancy is incredibly important. And that is something that I think is misunderstood in our culture, that, you know, you should go off medications altogether while you're pregnant, that kind of thing. But in this instance, this disorder really requires it for the health of the mom and the baby.
I think that's a really good point, and we hear that over and over again, especially I think the breastfeeding part is the other one. So we'll hear a lot of women who will say, well, my family say that it's not safe for me to breastfeed if I'm on methadone. And I think that's one of those key things that I've learned on being on these calls is that, yeah, that's actually, it's good for mom, it's good for baby. The other resource that I've started to hear is of labor and delivery doctors getting their X waiver so that they can prescribe methadone. So I think that's a nice initiative that's coming out. And I do know they're trying to work on, you know, rooming in, as well as addiction treatment centers that allow moms and babies to go. So I think there's still a lot of ways to keep going with it. But I do think the more we all know it, and I think the more we can help to dispel some of that, right? So I think that was one of the ones that stuck with me. I think I heard that from our nurse navigators who would say that the moms, right, the grandmother would tell mom, you know, this isn't safe or this isn't safe. And that's their predominant like information person in their lives. And so the more we can kind of help kind of give that support to mom, all the better.
That's a proximal influencer, because that's a powerful relationship.
For sure.
Coming from the children's services perspective on it, I think there's still some fear with parents or mothers who are getting the methadone or the Suboxone during pregnancy to kind of counteract their addiction. That does not guarantee that children's services won't be involved. I think it's kind of either damned if you do, damned if you don't situation. And that's a very scary thing for new moms, you know, whether I admit that I have a problem and I'm getting help, or I just don't disclose that I have a problem, it could have the same result in the end, is kind of just that fear and uncertainty, like, okay, am I going to be in trouble for addressing my substance abuse concern and being pregnant? So I think that's been a consistent kind of fear for some of the parents that we've encountered.
Thank you, Carly. That's a really great point. And also the last point on both of those medication slides is that it doesn't guarantee that the baby will not have NAS or now symptoms either. Donna, I also saw you come off mute. Go ahead.
I was just going to say that sometimes, like in our county, for example, we have been able to work. I run a group for pregnant women addicted to opiates, and we do MAT treatment. And going in, they all know that they're going to be, you know, have involvement with children's services, but we've established a really good relationship with them, that if they're in the group, they're screening negative, they don't even screen it in. And so they know that going in, that, you know, that this is, even if you've had history with them in the past, they're going to work with you if you stay clean and just use your medicine, you know. And it's worked real well for our group, for our women.
That's great. Thank you, Donna. Well, I recognize we are at time. Oh, sorry, Kathy. One more comment from Kathy Wedding. Go ahead.
I was just going to say, I think that that's what's most important for prenatal type treatment of these moms, is that that group has an association with Children's Services, and that Children's Services, you know, understands what is already in place. Because I think that we have so varied responses across the state, even, you know, one close county to another, that that's a big piece of education that still needs to go on. And I think the other thing is to have a list maybe of those organizations that do provide care for mom prenatally and for moms and babies after the fact, so that there are more situations in which moms can bring their babies back and go through that postpartum time period with their babies. And I think that maybe the knowledge of where those are or what those mean might be something we could work on also.
Thank you, Kathy. Yeah, if you know about those programs, feel free to put them in the chat box. That would help us out a lot, and we can always share that back out. I want to thank Dr. Nicole Knighty so much for kicking off our Buckeye Scope series. We really appreciate it. Learned a lot, saw some great slides that will be available to you later. Alicia, thank you for this wonderful case.
You're welcome.
Really great discussion.
Everybody just come along.
Yeah.
Everybody
well,
on the page.
and we really appreciate it because you kind of are setting the stage with, you know, it's pretty easy to share a challenge or opportunity. You just kind of let us know, and we'll put all the information on slides for everyone, and then we will kind of let you take the lead in the session. So in future sessions throughout the series, we'd love to have people share a challenge or opportunity from your work as well. So I'll put that plug in now and later. It looks like most people are back at this point. So what we'll do due to time is maybe go through a couple of our hub team members and to provide just one recommendation. At this point, I know we could continue to talk for a long time. And so Andrea, if you want to start, you've put some in the chat box, which is great. If you want to go with just one recommendation.
Yeah, the one that I wanted to bring up, the other ones are self-explanatory, but we talked about parent-child interaction therapy. We thought that would be a great way to build positive interactions between the kiddo and the adults in his life with someone who's trauma-informed.
Wonderful, thanks. How about Kristen Kerwin? If you want to come off mute.
Yep. Yes. We were talking about how to increase language. One of the suggestions was peer modeling using the other children, both for play and for language, to hopefully bring out some of his language.
Thank you, Kristen. And then Michelle Hendricks, were you in a different group than them?
Sorry. Yes, we talked about also incorporating the other children where possible, and we weren't sure if she had used visual schedules yet. Also, I was not familiar with this, but someone in our group had mentioned PACS tools, which came up when I was saying that something had worked for me was just to try to recognize what the child would view as a reward. So whether it would be hugs or, you know, some sort of silly reaction or, you know, kind of hyperbole to any progress or any time when he was, you know, willing to verbalize things a little bit and just remain consistent with that.
Excellent, thank you. How about Stacy?
We had so many. We talked about sensory profile or sensory processing work. And Maureen pointed out at the very end that there are new sensory processing measures that are coming out, and it's called the SPM2, and it has, you can do it on paper or online. It has a great online bank of ideas. And it's not just OTs who can do it, but anyone can administer it with an OT to analyze and help set up ideas. We talked a lot about making sure she can avail herself of other resources and early childhood mental health, and then a lot of physical sensory play, and then mirroring of the whispering and things like that.
Excellent, thank you. And how about John? One final recommendation from the group?
Yeah, we also had a lot, of course, but I think one of the central things that came up were multiple ideas around creating space and time to just do unconditional love kinds of things. I love you rituals, following the child's lead, being rather than doing with the child, just to create that trusted relationship in a space where there maybe isn't that element of what are you trying to make me do, but you're just being with me.
Wonderful. And I know we didn't get to all of our hub teams, so I know we didn't get to all of our groups, but there's plenty of great recommendations that will be shared on our challenge opportunity form that will be posted to the Canvas site and that we will share with you, Alicia. So more to come, but thank you again. You will win the first prize. So as good behaviorists, we will be reinforcing you with a reward for bringing this opportunity for us to learn from each other. It looks like there's some great comments in the chat around some things that many of us didn't know, PACS tools, and some other really great comments about PCIT and PECS communication. So thank you all. I want to just make sure that as we wrap up, we remind you how important it is to complete the evaluations, not only for your continuing education, but for our continuing quality improvement and making sure that we're responsive to the community's needs, and we can make sure to make changes throughout the series as we go. We definitely will plan to, and we as in me, will do a better job of time management so that we have more time in our breakout rooms. We always hear that. I wanted to make sure you all are aware of our Buckeye Scope newsletter. So if you did not receive that second iteration of our Buckeye Scope newsletter, please email Jessie and she'll get you added to our list. And then we've also just launched a Buckeye Scope Facebook page. So search for Buckeye Scope on Facebook and we'll be posting content there to keep us all involved and connected. So I believe that is all. We only went 1 minute over. Please join us in 2 weeks for our peer support session, which is a new session for Buckeye Scope series. So thank you all for your attention and participation today. It was wonderful.